A warm welcome to you all. This is a session on February 2010 question paper. And the first question is, describe the etiology, clinical features, diagnosis and management of a case of malignant melanoma. This is the first question. Now, what is melanoma? Melanoma is a cancer of melanocytes. So what are the various places where you can see these melanocytes? You already know you can see them on the skin. You can see them on the retina. You can see them on the mucosa. And they are also seen in the leptomeninges as well. Now coming to the etiology of malignant melanoma, the first and most important etiology is exposure to ultraviolet radiation. This is the most important point. So that is the reason why most of the melanomas arise in the sun exposed areas. Okay. So in which people you are going to see melanoma? White skinned or black skinned? Yes, they are seen in white skinned individuals. Yes, they are seen in white skinned races. Now, I told you that it is due to UV radiation, but some cases of melanoma may also get inherited in a autosomal dominant fashion. Okay, these are only few cases, that is 10 to 15% of the cases of melanoma are inherited in a autosomal dominant fashion. So what are the genes responsible for this? One is CDKN2A and the other is BRAF. These are the two genes I want you to remember. Coming to the morphology of melanoma, most of the melanomas are going to arise de novo. So what is the meaning of the word de novo? It is occurring in a previously normally pigmented skin. In previously normally pigmented skin. That is why I am calling it as de novo. But few melanomas, only 10 to 20% of the melanomas, they can occur in a pre-existing nevi. But most of them are occurring de novo only. Only few of them are going to occur in a pre-existing nevi. So clinically, you already know clinical features. It is just melanoma is just a asymptomatic lesion. Now, what are the various clinical presentations of melanoma? We will discuss. So the first variety is superficial spreading melanoma. Superficial spreading melanoma. So this is the most common presentation. If you ask me what is the most common presentation, it is superficial spreading melanoma. Almost 70% of the cases of melanoma are this type, that is superficial spreading melanoma. And another point I want you to remember is, it is spreading, means it is spreading in all the directions. It is spreading vertically and it is spreading horizontally. Okay, it is spreading vertically and horizontally in all the directions. Now the second variety is nodular melanoma. You already know nodular means there has to be a nodule. So you already know nodule means nodule can have only a vertical growth. It cannot have a horizontal growth. Now it is going to lack horizontal growth. As it has more vertical growth, if it has more vertical growth, what happens? It is going to be more aggressive. Any tumor which has a more vertical growth should be more aggressive. Okay. let's look into some pictures. So what is this? This is a superficial spreading melanoma. Why? Sir, there is a nodule also. But even though there is a nodule, I am not calling it as a nodular melanoma. I am calling it as a superficial spreading. Why? Not only nodule, I can clearly see a plaque over here. So this plaque is telling me the radial growth phase, whereas the nodule is showing me the vertical growth phase. When both of them are seen, it has to be a case of superficial spreading melanoma. Now, we will see nodular also. Here, what happens in this picture? I can clearly see only a nodule. If you see only a nodule, that melanoma has to be a nodular melanoma. Now coming to the third type, lentigo maligna melanoma. So what happens is there is no vertical growth for this lentigo maligna melanoma. That is why it is less aggressive. Okay, it is less aggressive or less metastatic potential. Now coming to fourth type is acral lentiginous melanoma. You already know what is the meaning of the word acral. Acral means it has to be in the peripheries, that is palms and soles. If you remember, I have already told you melanoma is mostly seen in white skinned races, but acral lentiginous melanoma is an exception for that. It is rarely seen in white skinned individuals. Okay, let me show you if I have a picture or not. Just a second. So here you can see the acral lentiginous melanoma. You can clearly see it is in the palms and soles. It is in the peripheral areas. Okay. Now, is it a white skinned individual or not? No, it is not a white skinned individual also. You can remember that. The most important in melanoma is this ABCDE criteria. So what is this ABCD criteria? A. What is A? Asymmetry. What is B? Border irregularity. What is this C? Color change. D. Diameter more than 6 mm. And E means evolution over time. This is ABCDE criteria for malignant melanoma. Let me show you again an example. So this is already a known case of superficial spreading melanoma. Now here if you clearly observe this picture, you can see two things. So I will make a difference. Okay. The part which is above that is pink tan in color, whereas the part below that is what in color? It is bluish black in color. Actually, this is a case of superficial spreading melanoma, which is pink tan in color, and now the below part has got a color change. Okay, and the below part has got a color change, and now it became bluish black in color. So the moment I see this border irregularity, and the moment I see this color change also, I can call it as a invasive one. So diameter and all within an image we cannot measure. So these are the features which tells us the potential to invasiveness. Asymmetry, border irregularity, color change, diameter more than 6 mm, and evolution over time. These are the 6 points which tells us. Now coming to the microscopy of melanoma, so you already know we are going to see what? Atypical melanocytes. But one thing I want to tell you here, the atypical melanocytes will be seen only up to dermoepidermal junction. Only seen up to dermoepidermal junction in case of melanoma in situ. Okay. No involvement of dermis is seen. No involvement of dermis is seen in melanoma in situ. Now coming to management of a case of melanoma, the first thing I have to do is I have to get a excisional biopsy with 2 to 3 millimeters of the normal skin also. Now what I am going to measure from this? I am going to measure a thickness called as Breslow thickness, very important. So this Breslow thickness, what is this Breslow thickness? From the granular layer of the skin to until where? Base of the tumor I have to measure. Sorry. So from the granular layer of the skin to the base of the tumor I have to measure the thickness. That thickness is called as a Breslow thickness, which is very important for melanoma. So one point I want to tell you here is this Breslow thickness is the most important prognostic factor. Most important prognostic factor, provided no lymph node involvement is there. Okay, no lymph node involvement is there. Provided there is no lymph node metastasis is there, the most important prognostic factor for melanoma is Breslow thickness. Now we are staging this melanoma into T1, T2, T3 and T4. So what is T1? If it is less than 1 mm, it is T1. What is T2? T2 is between 1 to 2 mm. T3 is 2 to 3 mm. Anything which is more than 4 mm, I have to take it as a T4. Now for T1, I need not do sentinel lymph node biopsy, but whereas for T2, T3 and T4, I have to get a sentinel lymph node biopsy done. Okay, I have to get a sentinel lymph node biopsy done. Next, how to treat a case of, the mainstay of treatment for melanoma is always surgery. So based on the thickness, now I have to remove the melanoma. Not only I have to remove the melanoma, I have to remove a rim of surrounding normal tissue also. What is the margin I have to take is based on the thickness. So if the thickness is less than, if it is a in situ, if it is an melanoma in situ, I have to take a margin of 0.5 centimeter. So wide local excision margin is only 0.5 centimeter if it is melanoma in situ. What if it is less than 1 mm deep? I have to take a margin of 1 centimeter for wide local excision. What if it is more than 1 mm deep? If it is more than 1 mm deep, I have to take a margin of 2 centimeter. This is differently given in different textbooks, but kindly follow this. If it is in situ, margin is 0.5 centimeters. If it is less than 1 mm deep, then the margin is 1 centimeter. If it is more than 1 mm deep, then the margin is 2 centimeter. If you remember this, then it's fine. Coming to regional lymph nodes, if there is involvement of regional lymph nodes, what I have to do? I have to get a elective lymph node clearance. I have to do. I have to remove those involved lymph nodes. I have to do. Now, is there any adjuvant therapy for melanoma? Yes, there is adjuvant therapy. What I can use is the drugs which can block BRAF. So what are those drugs? One is dabrafenib and The other is vimurafenib. Vimurafenib. These are the drugs which are blocking BRAF, which are used in melanoma. And the other thing, in the drugs which are acting on MAPK, what is the example? Trametinib. So these are the ones which are used in melanoma. Okay, that's enough for melanoma. Now we will move to the next question.